Thank you very much for inviting me to speak, to share a little bit about some of the work that the U.S. Centers for Disease Control and Prevention is doing. For those of you that don't know, that is a public health agency. That's the premier public health agency in the U.S. And so we approach ME/CFS from a public health point of view. And I don't have any conflict of interest, and while I'm telling you about what CDC is doing, I don't officially fully represent CDC. So I'm going to tell you the tale of two studies, and these are two different kinds of studies that will give us what we expect to be complementary information about ME/CFS. And as you all know, there's never one study that's going to give you all of the answers. And so by putting things together, we hope to get as full a picture as possible. And the two studies are things that I have mentioned before. That's the multi-site clinical assessment of ME/CFS, we call that MCAM, and the Behavioral Risk Factor Surveillance Survey, or BRFSS. Now, just as a reminder, the MCAM gave us the opportunity to work with clinical experts in ME/CFS, and I think this is really the key to making progress in this illness. You have to work with those who know the illness clinically. And the other unique thing about this is that our enrollment relied solely on the clinical opinion of the physicians. So we didn't require any specific case definition. We allowed the experts to tell us if this was a patient or not. And this removed that constraint because if you enroll by a case definition, then at the end of the study, interestingly enough, those who meet the case definition are in the study. So it's hard to evaluate a case definition then. The other key thing is that we enrolled from multiple clinics. And multi-site studies, I think, are increasingly important in order for us to get a full picture of what this illness is like. And we could ask even some very simple questions. Do the patients differ between clinics? Is this one reason why we're having trouble getting consistent findings? And how do these experts diagnose and manage ME/CFS? And another goal was to collect very standardized information on illness domains. This study really helped us when we collaborated with NINDS and provided data to the IOM when they were considering the case definition and the Common Data Elements working groups. So the participating clinics, there were 7 of them, and they're scattered over the U.S., and Dr. Klimas and Dr. Peterson are both here participating in this conference, and the others have all had years of experience in caring for patients. The BRFSS is an ongoing study that was established in 1984 with 15 states and now involves all of the states and territories. It's a phone survey that includes more than 400,000 adults each year. And the goal is to provide data on health-related behaviors, chronic health conditions, and use of preventive services. So this was established and ongoing for years. And the data is collected at the level of the states, and it requires participation of the state public health departments. Now, one of the important things we've learned is that local data is much more empowering to public health departments. If they know that it's an issue in their state with their people, they're much more likely to act on it than just some general information. So we think some local involvement will be very, very helpful. Our first approach to this was to ask BRFSS to include it. And initially, there were 5 states that participated: Alabama, Connecticut, Kansas, Nebraska, and North Carolina. You don't have to know where they are, but 5 of 50. And 3 of those states continued in 2016. Key to this is that in 2018, the modules, the questions about ME/CFS, were approved as optional modules that were, so they'll be available for states to use on a continual basis. Now, we don't know yet how many states have adopted them in 2019, but once it's available as an optional module and states start to see how the data is used, then more and more usually will go ahead and participate. So the data that I'm going to show you on the slides are from the 2014 and 2016 state data, and it involves 55,000 respondents. So just a comparison of the strengths and the weaknesses of each of these studies. The BRFSS, the strength is really the data is coming from the population. They are giving a self-report of a health provider's diagnosis, and the information is linked into the general health behaviors, but a limitation is there's really no biologic sample. And by contrast, MCAM, the sample and the patients all come from specialty clinics, so we know that the patients aren't really likely to be representative of patients as a whole. But the diagnosis is ironclad. We know that the experts are making the diagnosis. And we can ask a lot of very refined questions about ME/CFS, whereas in BRFSS we have to ask some very targeted small questions, and the health data is very general. And for for MCAM, we are allowed and we can collect biospecimens. So this is a slide that shows the comorbidity of people with ME/CFS as appeared in both of these studies. And the MCAM study is in orange, and the BRFSS is in sort of turquoise blue. And you can see that there's a lot of concordance in which comorbidities are most common. And arthritis up there is the top one, and that's because arthritis is grouped in with a number of conditions, including fibromyalgia, so we think that that is why that is so high. Depression and asthma are following, and you can see there is an area where there's a disagreement between the two studies, and one of these is in the area of cancer, and in MCAM we did not specifically probe a lot about cancer. So it could be the way the questions were asked. And when we look at the impact of the morbidities on ME/CFS, striking in both studies, most patients with ME/CFS had at least one comorbidity, and that's on the order of 80%. And that's very important for researchers to understand that if this illness very rarely occurs in isolation, and you have to account for that variation and variables when you do your studies. And you can see the graph shows the BRFS data in sort of the turquoise colors and the MCAM in the orange-brown colors. And those that have ME/CFS only are the light ones, and when you have a comorbidity are the dark ones. And you can see that the comorbidities have a negative impact on health and on physical distress and on mental distress. And these were questions from the CDC Quality of Life Health Questionnaire. And comorbidities also impacted illness by, as reflected in the number of visits that patients with ME/CFS had to doctors. And those with ME/CFS only had fewer visits than those that had comorbidities. Now, this is an example of data that we could only get through MCAM. And this is very detailed data on an SF-36, which is a very common measure of function. Function is very important, more so than fatigue, in monitoring trends of illness. And this data is shown normalized as a normalized T-score, and that means it's corrected for factors in the population and the culture so that the norm or the average expected is 50. And you can see that the green bars, the healthy controls in our population, are coming out with a score of about 50 on all of these measures, whereas the patients with ME/CFS have much lower numbers. The lower number shows a negative impact. And this scale is used often enough that we have established what is a meaningful clinical difference in the scores. And the meaningful clinical difference is 5 points. And so all of the scales show a difference, and you see the biggest difference in the role physical and the smallest difference in the mental health scales. This is, groups those SF-36 scores into two different components, the physical component and the mental component. And the MECFS, this is a histogram, a distribution of people's scores. And you can see there's, again, a very clear separation of those with MECFS and the healthy controls at the bottom. But what I want to call your attention to is really the distribution of scores. And this is a very important factor, again, for clinicians and researchers to understand that there's a lot of heterogeneity in the patients. And this means that just because a patient meets a case definition doesn't mean they're going to be identical to the other patients who also meet that case definition. So we have to find a way to capitalize on this heterogeneity and keep this in mind. And this is the kind of data that MCAM provides that is not available through BRFSS. However, BRFSS does allow us other information. One of the most important is we get an idea of prevalence. But now, of course, this is prevalence of having been diagnosed. And we found that there was a lifetime prevalence of 1.6%. And 71% of those that were diagnosed were still ill. So that came out to a current prevalence of 1.2%. And this is really very similar prevalence to that identified in the Canadian Health Survey that was questioned using very similar methods. The majority of those who report a diagnosis are female, and 80% of those with a lifetime diagnosis have functional disability in one or more of these very common areas. And then finally, I want to show you the barriers to healthcare. This is only possible, again, through the BRFSS. Again, it puts MECFS in with other chronic illnesses and in with the general US population. And the dark blue on the top are the respondents that had no illness. The light gray bar is those that have other chronic illness. The red bar is MECFS only, and the green bar is MECFS with comorbidities. And you can see in each of the barriers of healthcare, MECFS patients, for the most part, have significant barriers, much more so than those with other chronic illnesses. And this is really striking when you look at cost for healthcare and cost for medication. And so in closing, I would like to thank the study participants, the patients that took the time to answer all of our questions, and all of the healthcare providers that participated, the members of my branch and my division who support this study. And this is a picture of us, the whole branch, on May 12th, when it's not coming out very well, but we all were in blue. And then I also want to call your attention to, at the bottom there, where is CDC's website. Thank you.